everyone. We'll get started. Thank you so much for attending this month's Teach Educational Rounds. Here with us we have Dr. Meredith Giuliani, who will be presenting on smoking cessation in cancer care and how it's a fundamental priority. But before I hand it off to her, I'm just going to go over a few housekeeping slides as per usual. So if you're interested in obtaining a letter of completion for this Teach Educational Rounds webinar, please make sure that you have registered for this webinar and completed the pre-learning assessment. You have signed into this webinar using your first and last name so I can track your participation. And finally, you complete the post-learning assessment after the webinar, and I will send you the link to the post-learning assessment, and you will have 1 week to complete it. These webinars are being live tweeted on Twitter, and you can follow us at PS Quit Smoking and use the hashtag TeachWebinar to post or read questions. And while you're there, please make sure to use the hashtag BellLet'sTalk. Here's a biography of our faculty presenter, Dr. Meredith Giuliani. Dr. Giuliani is an assistant professor in the University of Toronto, Department of Radiation Oncology, and a radiation oncologist at Princess Margaret Cancer Centre. She received her MBBS qualifications from the University of London, England, and her Masters of Education from the University of Toronto. She is the Education Director for Princess Margaret Cancer Centre and the Cancer Care Ontario Toronto Central South Smoking Cessation Champion. Here's a list of her disclosures, as well as our disclosures. And remember, the content of Teach Educational Rounds are centered on evidence-based guidelines from the following sources. These materials, as well as the verbal presentation and any discussions, set out only general principles, and they do not replace the need for clinical assessments or treatment plans by healthcare presenters. And before I hand it off to our presenter, I'm just going to do a few polling questions to gauge who has joined us here today. So in a minute, using your computer, could you please indicate which of the following organizations you work for? And if your organization isn't here, please feel free to type it in the chat box. So it looks like we have some family health teams, some public health units, hospitals, that's great. And in the chat box, we have CNRC, Pan-Canadian Health Organization. Awesome. And again, using your computer, please indicate which of the following disciplines you are a part of. And you may need to scroll down to see all the options. So it looks like we have quite a few registered nurses. Some health promoters and educators joining us. And in the chat box, we have a radiation therapist. That's great. And finally, the last question, please indicate which of the following regions your organization serves. Toronto and Greater Area, Eastern Area, Central East Area. Welcome from Nova Scotia and Alberta. Okay, so with that, I will leave it to our presenter to take it away, and thank you, everyone. Enjoy.
Great, thank you, everyone. So those of you joining from the Toronto area, I hope you made it into work okay with all of the snow. So we're going to spend the next 40 minutes or so looking at the role of tobacco cessation in cancer care, and then looking at some strategies for implementing and maintaining a cessation program, and we'll end with discussing some work we've done looking at informational needs for patients and caregivers. So there is a chat box on the side for questions. Forgive me if I'm not looking at it all the time and if I missed one, but we'll make sure we have time at the end for questions. So why did I title this fundamental priority? And why do I think tobacco cessation is so important for cancer care? So we're going to go through some of the evidence. Oh, sorry, yeah, speak a bit louder. Is that better? Okay. So we're going to go through some of the evidence. I've chosen some select specialties and diseases, but there is really evidence for sort of every aspect of cancer care in the different subspecialties. So we know that smoking in Canada has been slowly declining in the last 50 years, and this is a good thing. However, our cancer patients are more likely to be smokers or have a history of tobacco use than the general population. We know that tobacco use contributes to over 30% of cancer deaths, and at least a quarter of our patients have a history of using tobacco products, and many continue to use them either at the time of diagnosis or even after. And this presents a real opportunity for us to intervene and to help them sort of achieve better outcomes from their cancer care. So what happens if you continue to smoke and use tobacco products once you've been diagnosed with cancer? So your treatment is less likely to work well, and I'll show you some evidence of that. You're less likely to survive, both from your cancer and from other causes. Your quality of life is going to be worse. Your treatment-related toxicities are worse, and then you have an increased risk of either your cancer coming back or developing a subsequent cancer. And we'll look at some of those, some specific examples. So this is in the surgical literature. That was great to see we have such diversity in the audience today. But these were two studies. One was in colorectal surgery, one was in lung cancer. And they basically looked at morbidity and mortality of colorectal cancer patients, either who were able to stop smoking or continue to smoke. And you can see that they were much more likely to have complications if they were continuing to smoke. And the lung cancer analysis is very interesting because it was not only a benefit for cessation, but actually the longer you had stopped, the more benefits you received. So that sort of gives us this burning platform of, if we know people are using tobacco products, we know that from diagnosis to interventions like surgery, there isn't often months and months of time, and so we do need to intervene as soon as possible, because the longer they stop, potentially the more benefit there is. What about other treatments? So I'm a radiation oncologist. As you heard in my biography, I treat head and neck and lung cancer, so I put a couple of head and neck examples in here. This is a picture of oral mucositis. So for those of you that aren't familiar with that, that's basically like a sunburn that you get on the inside of your mouth from having radiation treatment to treat head and neck cancers. And if you've ever bitten your tongue, you can imagine how painful this condition is. It's one of the major reasons why people might not be able to finish their course of radiation. They might need supports like feeding tubes, or they might have a break in their treatment, which is something we know can cause recurrences. So if you continue to use tobacco products and smoke when you're having head and neck treatment, the duration of this mucositis is longer, and they tend to get worse mucositis. And for people that are having treatment to their voice box, so for laryngeal cancer, one of the main outcomes beyond curing the cancer is wanting people to have good voice quality. Voice quality is very important for your quality of life. It's very important for your profession and for safety, to be able to speak on the phone. And for the people that continue to smoke throughout their radiation treatment, their voice quality is not as good as either never smokers or people who are able to stop. And what about second cancers? So there are many publications on second cancers. Two that I sort of like to talk about. One is in breast cancer patients, and if they are smoking, their risk of developing lung cancer is much higher compared to non-smokers, and we're getting very good at curing people or people living a very long time with breast cancer, and so these risks of second cancers are very, very relevant. And the same with Hodgkin's disease. So Hodgkin's disease patients, for the most part, tend to do very well, and they tend to be young at the time of their treatment and the time of their diagnosis, and so intervening and getting them to stop smoking is very important, because you can see there's a relative risk of 21 of developing lung cancer, so it's very, very high. And this is an example in prostate cancer. So this is a very large study with 1,000 patients of all different types of prostate cancer, so low risk, intermediate, and high risk. And they basically said, what was their cause of death? So what was happening to these people after they had curative treatment? And you can see at the bottom, deaths from prostate cancer is really less than 10%. So we're doing a good job of curing even some people with quite high risk prostate cancers. But they're dying of other things. And these other things that they're dying of are largely cardiopulmonary diseases. And on their multivariate analysis, really the driving factor is current tobacco use or any history of tobacco use compared to non-smokers. So in these patients where, in these papers where we're doing, or these sites where we're doing well with curing people, there's really an impetus to make sure that we're not continuing with health behaviors that might affect their survival and lead to causes of death from other causes. So smoking cessation interventions are one of the most cost-effective interventions in healthcare. I'm not going to get into that in more detail. There are others that are actually doing a lot of modeling work around the cost of different types of interventions and different intensities of those interventions in the cancer population. But we do know that if people continue to use tobacco products, they're more likely to incur higher healthcare costs. And there's different levels of things that can be done. There's non-pharmacological interventions in the 3 A's, and I'm going to go into that into more detail, and then obviously pharmacological, which we're not really going to get into. So what are the strategies for implementation? So these are reports from major organizations, think places like ASCO, the NCCN, the U.S. Surgeon General's report, Cancer Care Ontario, and they're telling us that we need to have smoking cessation programs. And so we can see that these things are popping up. Ontario has really, through the leadership of Cancer Care Ontario, come a long way in the last 6 years since that report that mandated that all programs have a cessation program to now. Tens of thousands of patients have been screened. Some of this work, so Graham Warren is a radiation oncologist in South Carolina, and in the U.S. things are a little bit more mixed as to the sort of prevalence of smoking cessation programs. But what Dr. Warren and others have done, they've polled thousands of oncologists through major organizations. So the IASLC is the International Association for the Study of Lung Cancer, and then ASCO. And they really wanted to know, what are people doing in practice? So are they asking people about tobacco use? Yes, you can see that's 90%. Are they asking people if they're willing to quit? Yes, a very high proportion are. And are they telling them that that's probably a good idea? Yes. But where we get to the act, so asking and advising, that seems to be happening. But are we getting to the act? And you can see that that seems to be a pretty big gap. So in terms of discussing medications and actually managing the cessation treatment, things really fall off down into the sort of 40s. And that is, I'll show you some of our data from my institution, but that is a knowledge to practice gap that we experienced as well. And so even from providers, there is a gap forming there. So what are some of the implementation considerations when you're thinking of a smoking cessation program? So this is a disease. Cancer care is increasingly multimodal and very complex, and introducing more things into that complex pathway can seem daunting. There's an urgency to care. So when we looked at some of the surgical examples and we saw the benefit from an increased duration of cessation, as I said in the beginning, we often don't have months before people get to their cancer surgery, before they get to their radiation. And that's a good thing because these are diseases that need treatment, but that urgency can create a challenge for implementing smoking cessation programs. The potential for psychological distress, there's a lot going on. I think we would all recognize that for the patient and their family, and the acute and long-term effects of just the cancer treatment themselves. And so patients, so there is a teachable moment around diagnosis, and I'll show you some data around that, and that there is a period of high motivation, and that's something that we want to be capitalizing on. And people need information. And we'll show some of the information priorities that we were able to ascertain from people. And there is that issue of stigma. And that can be a challenge for providers for engaging with people. Providers can have a lack of awareness and a lack of training. There can be resource and time constraints in the clinic. The audience here represents sort of the whole spectrum of the cancer care sort of professionals, and I think we all know from where we interact with the system that things are very constrained. We're very busy. People can often be very unwell, and trying to add other things into that system can be a challenge. And then sometimes we see issues of fatalistic beliefs that still is prevalent amongst providers, where people think that there isn't that benefit, and they're not aware of some of those data that we went through at the beginning of this talk. And the desire to not overwhelm patients. They're new, we don't have a relationship with them because they're a new patient, that concern about stigma, and maybe diagnosis isn't the right time. And so we as this group of people that are engaged in tobacco cessation efforts, we need to help educate our colleagues around that teachable moment and around the benefits of cessation, because that information isn't out there for everybody. So the teachable moment. So this is some work led by Lawsoning. At the time he was a medical student, and now he's a medical oncology resident. But he asked over 1,000 cancer patients this is going back and asking about their experience of quitting. And you can see that in that red circle, really around the peri-diagnostic period, 0 is diagnosis, is when most people quit. Over 65%, that's where a quit attempt was happening. And the reason that there's sort of the tail in the lead up to time 0 is that even though you don't officially have your diagnosis, people are having investigations. There's maybe a high suspicion that there's maybe a cancer. They may be unwell from whatever's prompting those investigations. And so that peri-diagnostic period is a period of high motivation in quitting. And we should be targeting interventions at that time period. And this is some evidence that you can draw on when people say, new patient, first appointment, it's not the right time, you're overwhelmed. You can draw on this evidence to sort of say, well, actually maybe it is. Maybe people are already thinking about it. So what's the role of the provider? So we know that and just doing those brief 3As can significantly increase patients' motivations and then subsequent success. And the 3As models that we'll get into, it doesn't have to take a long time, but we do want to capitalize on that teachable moment. And I think what we really need to do is provide accessible knowledge and confidence building opportunities for our clinicians. And they need to be brief. People are very busy. Not everyone's going to take this up as their the sort of main thing that they're doing, but if we can get everyone to make a small change in their practice, I think that really has the opportunity to significantly move the needle to get more people screened and more people to cessation activities. And I'll show you at the end some very brief educational opportunities that we've engaged in with our community. We also felt that we wanted to bring our community together. So in collaboration with Toronto North and Toronto South, we have held, for almost the last 5 years, a community of practice event every year in the fall. And really the idea is to bring everyone together. We wanted a networking opportunity. We wanted a chance to discuss emerging evidence in cancer care, and we wanted a chance to discuss knowledge translation strategies because every cancer program is unique. Every set of health professionals organizes their care in slightly different ways, and those nuances are actually very important. And so having a chance to bring the community together, we found is very valuable. This is one of our community of practice days, people huddling in small groups. People were really keen on working on education together. We felt this was a great opportunity to share resources and to share where people thought the most areas of need for providers and patients were. People found similar barriers to the things that we'd already discussed in the higher slides, so resources and competing priorities in the clinic and that education gap. And people wanted to stay connected. So that's where we've tried to continue to have these community of practice events. And just in case I forget to come back at the end, if you are in the Ontario area and you would be interested in coming, my email is at the end. Just let me know and we can add you to our invitation list. The next event will be in the fall, October, November time. And so the Cancer Care Ontario framework, so I know not everyone here is based in Ontario. And other provinces have their own frameworks, but just to briefly go over what happened in Ontario. So back in 2012, they mandated that all new ambulatory cancer patients should be screened for tobacco use. And this was really great because now it was a priority from our major organization for cancer saying that this needs to happen. And some hospitals and cancer programs already had programs to screen and support people, and others had nothing. So it was an opportunity for people to get something off the ground and to come together on a monthly basis to talk about things and to share, and also to be educated and to educate their colleagues. These metrics that Cancer Care Ontario collects are publicly reportable, and they're tied to our quality scorecard. So I think that just shows the level of commitment to how important this is. And they really went with that feeling of this is critical. And we and others have implemented an opt-out approach. So when we talk about cessation activities, it's not really something that should be seen as optional. It should be seen as mandatory. So as a radiation oncologist that treats head and neck cancer, my patients often need to see the dentist. And not everyone wants to go, but we know that it's a very important preventative measure to prevent complications like osteoradionecrosis. And so we've tried to treat tobacco cessation that way, that it really is a fundamental part of their care, and to encourage people to engage with that. So the 3A's model, so just in case people aren't familiar with, we used to have a 5A's model, and the new model is 3A's, so ask, advise, and act. And that really emphasizes that opt-out. So you want to talk about it, you want to tell them it's a good thing, and then you want to help them. And helping them, if you just reflect on your own clinic, it doesn't have to be that you as the oncology provider are taking over all of the prescribing or dealing with all of the cessation work. What we actually do, and I'll show you our workflow, but we actually have partnered with our colleagues in pharmacy, our colleagues at CAMH, and our colleagues at the smoke, the quit line, and to try to get people to the services that are really equipped and are specialists in managing these things. But having that provider recommendation and that almost prescription from your oncologist can significantly increase motivation. And just because people aren't ready the first time, having a mechanism to come back to this issue at subsequent visits and engaging the whole team is something that has been shown to be very helpful. So these are the metrics that Cancer Care Ontario is interested in capturing. So they're interested in the percentage of new patients that are screened, and they want to do that within the first 28 days. And our target is 70%. They're moving some of these targets. But these are our current targets. The percent of patients that are either current smokers or recent quitters, and that's their definition is within the last 6 months. The proportion that are advised to quit, those that are offered a referral, and then those that accept that referral. And then we break it down into is it an internal referral or an external referral. But we're trying to get around the 20% accepted referral mark. And I didn't put a slide in here about the number of quit attempts, but one of my colleagues at the Ontario Tobacco Research Unit presented some very interesting data that said, people often think the number is kind of 5 or 6 attempts before when people are trying to quit. They had some data that actually said it might be upwards of 30. And so normalizing that need to come back to the issue is very important. And so although we're trying to get people to accept referrals, we know that we may need to come back and revisit the issue. So these are the 4 pillars of our program that we're going to review. So our e-referral system, our patient education system, our provider education engagement, and then our monitoring and reporting. So our e-referral system, so CEASE is just an internal name for our system, and this is what we use to screen our patients, and it's an electronic system. So this is the workflow. So all of our new patients are screened for tobacco use. I'll just answer Mark's question very quickly. So about the initiation of products. So Mark, that's actually down to individual healthcare professionals. So, some may be providing prescriptions, others may be facilitating a referral, and those referral centers like CAMH or the pharmacist might be doing it. So we're not so prescriptive to people. We tell them that whatever they're comfortable with and whatever works for their patients. So I know some of the surgeons do actually start prescriptions and others wait for the referral services. Our colleagues who actually see these patients see them very quickly, and we worked on ways to sort of facilitate those referrals to speed things up because of that issue of we don't have a lot of time before they start treatments like radiation and surgery. So sort of back to the workflow. So patients are screened at their new patient visit ideally, and then they're triaged, either someone who is not a smoker, and that's just documented, or if they are either currently using products or a recent quitter, they receive a brief education, and then they're provided referral options and why they might want to pick one or the other. And then they can either accept the referral, and the system will generate an e-referral, and that is also information is provided to the clinicians so that they can reinforce it. And if they decline a referral, they can discuss that further with their healthcare team, who can then initiate a referral after, or they can be reassessed. So Cancer Care Ontario doesn't mandate reassessment, but it's something that we wanted to put into our program because one, we wanted to know what's happening to our patients after they had been screened, and also we know that going back and having a quit attempt that may or may not be successful is very common, and we wanted people to have an opportunity to be re-referred if that was necessary. So these are our screens from CEASE. This is delivered on an iPad, so when they check into the clinic, our team that checks them in checks their new patient information, and then gives them an iPad. The reason it says DART at the top is that we also do distress screening and ESAS screening, and so our tobacco screening is actually integrated with several patient-reported outcome measures that are mandated for new patients. And so that means that it's a slightly smoother workflow from the clinic perspective. We had initially started with a paper-based system, and I'll show you the data afterwards from the paper-based system, but it was cumbersome for the people organizing the clinic because they had iPads to give out, they had papers to give out, they had new patient information to check, and so when we spoke to people, they said that it was difficult to operationalize in the clinic, and so when we had the opportunity to move to electronic integration, we found that very beneficial, and I'll show you what that did to the numbers. So just to answer Jenna's question about how does the 6-month reassessment work. So I'll go back up to the workflow. So if you were identified as someone that was currently using tobacco products or had quit within the last 6 months, so you've gone on this top sort of journey, the system will remember that that was your answer. And when you come back for a visit, they're given these iPads at every visit because of the distress screening. And so the system knows when you hit around the 6-month mark, it doesn't have to be exactly 6 months, but when you're at the 6 months or slightly after point, and you had gone up this pathway initially, it will automatically trigger a reassessment. And the reassessment screens are very, very similar to these original screens. They just don't say for new patients, they say they're a 6-month reassessment. So we collect information about whether or not they currently use tobacco products, and that allows us to move either up or down that yes or no pathway. We do collect information about their exposure at home, and I'll show you why with some data in just a couple slides. This is our brief targeted education. I'm sorry, these are a bit small, but I am happy to share this with anyone if you're interested afterwards. So we talk about some of the brief benefits of tobacco cessation in the cancer care context specifically. And then it moves into referral options, so Smokers Helpline, Nicotine Dependence Clinic, and the outpatient pharmacy. So I'll just pause here. There's a couple of questions popping up. Is the 6-month follow-up done by the Cancer Center of the Smoking Cessation Program? So that's a great question. So the pathway I just showed you is within the Cancer Center, so that's within our CCO program logic. It rescreens them, but depending on where they've gone for their referrals, some of their cessation programs may also be following up with them. So if we go back to the pathway here, if this has triggered a 6-month reassessment, they come back to that first screen that says, have you used tobacco products? If they then indicate no, then we would just document that. But if they indicated yes, it would move them through. And if they wish to reinitiate a referral, they could do that at the time. So it's basically an opportunity for the team to know what was going on and to help either say, great job for stopping and all the benefits of that, or maybe people weren't initially ready and now they are, and to help facilitate that. And just a question about e-cigarettes. So that is a great question. We haven't specifically asked about e-cigarettes. The wording is tobacco products, and we've just sort of used that catch-all. But we haven't specifically flagged e-cigarettes, and we also haven't done anything about the smoking of marijuana. Those are two things that we have sort of talked about as a group, but we haven't specifically moved in either of those directions. So Margaret, when you say team, so the team is really anybody that's working with the patient. So in the sense of the people that are organizing the clinic, those we call them patient flow coordinators and patient care coordinators. So they are the ones that help us with the distributing of the iPads initially. And then the information is printed in the back of the clinic. And each clinic in my institution and in many others is operationalized in slightly different ways. And so the first person that may see the patient in some contexts may be the nurse. In some contexts it might be a medical learner. It might be their physician. So who's ever going in first has access to that information. And we've really left it up to individual clinics on how they want to deal with those nuances, because there's so much complexity in the way clinics are organized, and they really run as kind of well-oiled systems. And so we were trying to provide them with helpful information, but not disrupt the way they kind of have things optimized. So I'll just walk through the paper versus electronic situation that we had. So these slides that say pre-implementation, this was before our CEAS platform when we used paper. So what would happen with the paper system is new patients would check in. They were given a paper screening form that asked very similar questions to the CEAS questions, and they were also given an iPad just to screen for the other patient-reported outcomes that are mandatory. And we were screening around 40 to 44% of people, and about 17% were either current or recent, were identified as using tobacco products. Current smokers were around 67% and recent quitters around 21%. But what we saw was a really high willing to quit. So around 76% were willing to quit in the next month, and that was great. So we were seeing that high motivation that we had seen in that previous publication by Lawson Ng, where we're really in that teachable moment. So people are motivated, so that was great to see. But where we were falling off is that the recommending a referral, which we were asking the healthcare team to sort of take these paper forms and then discuss it with the patient and then initiate the referral, there was really a gap there. And so even though patients were motivated, the referrals weren't happening for a variety of reasons. And so our overall referral rate was low. So our overall referral rate was only 6%, and people that were actually getting to the referrals was kind of 9%. So that was obviously a gap. We had motivated patients that weren't getting to the cessation services. So we sat down with the team and said, you know, what would help? And that team was the PFCs and PCCs, the nurses, the dentists, the pharmacists, our colleagues at CAMH that sit in our working group, the physicians in the group, and we said, like, where do we think this gap is coming? And that's when we heard that having to provide paper and electronic was difficult because people are juggling lots of things. The clinic is very busy. Lots of people are trying to check in at the same time because new patients are often seen early in the sort of clinic roster. And so they said, you know, if we could just integrate this and have one thing that we have to give out, it'll be a lot smoother. So we had some grant funding to pilot that. And while we saw the number of screens go up, which was great, we had the same willingness to quit, but we saw that the recommended referral went way up. And so that was good. And we saw that the overall referral rate went up to 27%. So we were really closing that gap by being able to get people at least to the services. You know, people may not follow through with the referrals. Lots of things can happen. They get busy trying to get on treatment, or they may try and they may not be successful in their quit attempt, but then that 6-month reassessment can catch them. And this graph shows the transition. So from pre-implementation, we were entirely paper, and you can see that very quickly we had a rollout of different clinics. We didn't do the whole hospital at the same time. We have 13 different disease sites, and so we brought on 1 or 2 disease sites every few weeks, basically to try to work with the individual sites to try to make sure that the workflow was working for them, and if anything needed to be adjusted, we did that before we moved to the other sites. But you can see that very rapidly paper usage went way down, and the electronic usage went right up. You can never fully get rid of paper, at least not in our context, because there's electronic issues that can pop up. You can have electronic downtime. You can run into patients that are not comfortable using the electronic interface. You can have Wi-Fi issues. So our iPads use Wi-Fi to connect to the medical record, and so sometimes there's downtime there. Or we were having a renovation, and there were some pockets where the Wi-Fi wasn't good, and while we were waiting to have that fixed, so we had paper as a downtime. Translation was also an issue. I don't have any of our translation screens in here, but in our area, we have lots of patients where English is not their first language, and so we worked with the symptom control team who does the DART screening to implement translation, and that's sort of something that's ongoing now, but to have not only English but other languages. And electronic really helps you there because it can screen in another language, but it can print a report in English. So that is helpful for the healthcare team. So I'll just pause there for 1 second and just go to the 2 questions. So to Monica's question about NRT, yes, radiation patients can receive nicotine replacement therapy. And to Mark's question, what percentage of those who referred attend the intervention? So I don't have those numbers with me. There is a drop-off of sort of over 50% that actually follow through. And there's a number of reasons behind that. It can be that they get overwhelmed with starting treatment. One issue is coming back down for appointments, and that's why that we wanted to have that reassessment at 6 months when sometimes things are a little bit calmer for people and they can revisit the issue. We have had meetings with our referral partners like the pharmacists, and they do try to follow up with people. They give them 2 or 3 phone calls and try to sort of work around their schedules. But that's another area of that you need to work on. And it's one thing that we've actually wanted to sit down and talk to patients about the people that don't actually, who are interested but then don't actually make it to their appointments. There are groups that we really wanted to talk to, but they're a challenging group to study, as you can probably imagine, because there's sort of all kinds of reasons why people don't follow through with appointments. So it's a really good question. It's an area that needs to be better understood, for sure. So what about the follow-up patients? So these are some more recent data from the last fiscal year, but because of the way our electronic platform works, even though it's given to people on every visit. So if for whatever reason they didn't receive the screening at their new patient visit, they may not have been counted as that new patient number for Cancer Care Ontario because that's in the first 28 days, but the system actually doesn't care. The system will ask you those smoking cessation screening questions the first time that you log into it. So if you've been a patient and for some reason you haven't encountered the electronic screening in the first 3 months that you've been there, if you get it in your 3rd month, you still get asked the questions. And so we do track the data for our follow-up patients, and you can see for the period of time for this data, there's about 11,000 new patients. We still screen almost 8,000 follow-up patients. And from a healthcare perspective, we want people to access cessation services. So if they were missed as a new patient, although that's not ideal, we're still trying to catch them at other time points. And you can see that even these people that aren't caught as in the period that's defined as a new patient, there's still kind of very equivalent levels of motivation to accept a referral. So we like that with our electronic system, is that it helps catch people that may have been missed in that new patient window that would not have been caught in other mechanisms where it's only a new patient thing that triggers intervention to them. So just the question about the mucositis issue. We don't fully understand what causes that, but it's probably more the hypoxia and not the nicotine. So that's why stopping smoking and if that involves pharmacological interventions, that is okay. And to Claire's question about the medical directives for nicotine replacement, so we have, so our organization, so our cancer center is actually integrated in a larger hospital network. And so from the inpatient perspective, there are order sets that can be used for inpatients. They used to be paper-based, and now they're part of our electronic medical record. And they kind of look like actually insulin sliding scales. So there's kind of a baseline for nicotine replacement based on the amount of tobacco products, and then there's other breakthrough things that are on formulary. We don't have something right now as an outpatient like that. There's kind of ready-made scripts, but we do have them on the inpatient. So monitoring and reporting. So we had this electronic system up and running, and that was great, and we worked with the teams. And if any of you are thinking about moving to electronic, just some of the lessons learned are it's really an iterative process. You really need to work closely with the people that are organizing the clinics however your team is structured. You need to understand from them, do they have enough electronic devices? Are they located in a place in the clinic that is convenient to be given out? You have to work with your infection control teams on how they need to be cleaned. There's very specific procedures about that before they're moved to different patients. You need to work with your digital teams to know if you have Wi-Fi issues. There's ways that they can go and test the strength of the Wi-Fi to make sure that that's okay. And you really need to work with the team, and you need to keep track of what's going on. And I'll just walk you through our tracking system. So we have this traffic light system, which people have for, they use traffic lights for lots of different reporting. But we really need to keep this on people's radar because people are very busy. The whole team is busy. There's lots of competing priorities, and things can kind of slide off the radar. You have turnover of the team, and when you get new team members and they walk into an environment that's very busy and there's lots of things going on, that's a lot to be onboarded and a lot to kind of learn. And so you need to have feedback to the clinics to allow them to sort of know what their individual clinic's performance is like. So we have a monthly reporting system. We use the traffic light as sort of a brief visual, and we track our overall, our sort of total screening rates. And then we track it by disease site. And we let people know if they're green, you're good. If you're orange, you're kind of in the watershed area. And if you're red, there's areas for improvement. And then the arrows are up or down based on how they've performed in the last month. But what's really useful for us is we can see the trend. And that's why we provide a few months at a time, because when we see things like 75% to 41%, something has happened, especially when we can look back and we can see, it might be 6 months and they're always at 70%, and then all of a sudden they drop down to 40%. And things that we've identified in the past were that Wi-Fi issue. So there was construction, and we didn't realize, and the team didn't realize that there was a Wi-Fi issue that needed to be addressed, and the data wasn't coming in. Another clinic, there was a really high turnover of the staff, and there just weren't enough, they just needed more time to get used to the procedure, and so one of our team members was actually there auditing the clinic and helping, doing a bit of an ethnography and sort of working with the team to see, how were things positioned, was everything in a convenient location, how could we help them give things out. In another clinic, there was actually a technical issue, and they were trying to figure out who they should contact about fixing that technical issue, and that took a couple of weeks. And so ultimately, everyone found out about it and it was figured out, but being able to track what's going on in relatively real time, that is really important. And the reassessment, so we actually kind of already spoke about this, but I'll just show you that we are capturing kind of 8,000 people in a year in a reassessment, and there were still about 8% that were current smokers, so that number was lower than our initial numbers, which kind of hang around 17%. So people are stopping, which you would expect based on that data that we showed, but we still have around 20% accepting referrals. So we do think that it's valuable to check in at 6 months. We're also checking in at 12 months. Because there are people that are still interested. Either they weren't interested in before and they are now, or maybe they tried and they want to try again. So if you have an opportunity to reassess, then that might be very valuable. So we'll just spend the last few minutes looking at the informational needs. And so we'll look at patient education and we'll look at provider education. So this is some work led by Dalton and Lawson. When Dalton was a medical student, he's now an emergency medicine resident. And we were interested in asking our patients, what do they think about the harms of continued smoking? And you can see that really people either don't know or disagree that things are not good. So we asked them about, do we think that smoking increases the risk of surgical complications? Do we think it asks the increased risk of radiation side effects? Does it impact quality of life? Does it impact the risk of death? And really, there's a knowledge gap here. And so that's why it's very important to provide information that's based on specific benefits for cancer. And so we did an informational needs assessment for patients and their caregivers. We wanted to know what were the most important areas for them and what were the most important information, because when you develop educational materials, they can only be so long to be accessible. And so we really wanted to know what the priorities were. And why did we ask caregivers? We asked them because this is part of that same study from Lawsoning that I showed earlier, but this is breaking down that curve into people that are exposed to smoke at home and those that aren't. And you can see if they're exposed to smoke at home, they are much less likely to quit smoking. And so we have targeted our information to their kind of the family unit. Because we know if that's one really supportive thing that can happen is if they can have a quit attempt together, that's just going to be more successful. So we asked about smoking behaviors, and I just highlighted a few. And I think this is probably something that we all recognize in our practice, but it's part of routine. They're concerned about withdrawal symptoms, and they're smoking because their friends and family smoke. So these are things we need to be aware of when we're organizing our program. And then we asked about the most important domains. People want to know about the benefits to their health, and then they want some information and support. This is from the patient's perspective. The most important things that people wanted to know are how is this harming their cancer treatment. People in general are aware of the dangers of smoking because they see it on the plain packaging, they hear it in the news, it causes heart disease, it causes cancer. But when you already have a diagnosis of cancer, they want to know, what is it doing to my treatment? What is it doing to my outcomes? And so you want to get a bit specific. And then they want some strategies. How can they stop? How can they stay quit? And this is from the caregiver's perspective. We've heard the same thing. They want to know, why is continued smoking harmful to their cancer treatment, and what is the impact? And so if you're developing materials or you're adopting materials, because there's a fair amount of materials out there, you want those cancer-specific materials because this is what people are motivated by. And how do they want to receive the information? Pamphlets or written materials were the most popular, followed by individual teaching with their healthcare team. We did ask about videos and group chats and things, but these were much less popular. Yeah, so to Mark's question, that's a complicated issue around dealing with the secondhand exposure. And so our approach has been that we let people know that one of the things they can do to help is to try to quit together or try to quit with other people that are living with them. And then a lot of the referral services, like Smokers Helpline, people can be referred even if they're not a patient. And so if people say, what can I do? Can I quit as well? You can actually send out 2 referrals for other people. So just to summarize the needs assessment, so we know that patient and caregivers don't fully understand the benefits of cessation in the cancer care context. And we really need to have targeted informational support on the benefits to their cancer. Ideally pamphlets and also reinforced by the healthcare provider. These are some of our pamphlets. There are more. The Canadian Cancer Society has some. You can download from their website. The Cancer Care Ontario has some. ASCO has some. So there are resources out there. You don't need to invent your own. If you're interested in these, let me know. I can get our librarian to share them with you. And we've translated them into our top 6 languages for Toronto. And it really focuses on those top 2 needs that people identified, which are how it affects their cancer treatment and the resources available to them. We have posters. These are throughout all of our outpatient areas, the clinics, and the treatment areas. And it talks about the benefits of cessation. And the very bottom, which I don't expect you to read, but in that gray box, has the referral phone numbers for our referral partners. So if people want to call, they're absolutely welcome to do that. We have a video series. They're very short micro videos. They're tips for quitting, why people would want to quit, and then one is a program-specific one that just talks about our program to help orient people. We created brief e-learning modules covering those same learning objectives. And what about providers? So we heard at the beginning with Graham Warren's survey data that people are asking about tobacco use. But where things are sort of running into trouble is the acting on it. And so, as I said, in our program, we don't mandate it that the oncology providers are prescribing, but we want them to help get people to referral agencies or people who specialize in it. They can certainly prescribe if they want to and they're comfortable with that. But where we wanted to move the needle was at least to get smoking cessation to be a priority for our team, and for people to know one or two facts that they can tell people about why it's important now that they have a cancer diagnosis, because that's what people really wanted to hear about. But providers are busy. There's lots of continuing education that's going on. People have a lot of competing priorities, and so we really wanted to have what we call micro-learning. So one objective, one area that can sort of impact their practice very quick, kind of 90 seconds, teach one thing that's very important, and maybe come back and do something else the next year. So we've done some provider e-learning, which we're building. It's really based on the 3A's model, and it's meant to be very quick. We did some videos. This is working with our larger team with the whole hospital. These aren't all specific to cancer, but it just basically covers things like identifying symptoms of withdrawal. These were made around the time that we were launching those pre-printed orders for the inpatient units, and also when the smoke-free grounds legislation is coming through, so some information about that and what to do about discharge. So these are a little bit more oriented to the inpatient team. So we're approaching 10 minutes to go. So the things I hope you took away from this presentation is that it really is important that we are assessing our patients for tobacco use and assisting those that are using tobacco products to access cessation services. We've had success with electronic screening, and its integration can be sustainably done in comprehensive cancer centers. Many patients are not aware of the benefits of cessation or the continued harms of using tobacco products, and there's a lot of work to be done around educating patients and providers, but we really need to be targeting our education to specific harms and the specific benefits of cessation activities in a cancer care environment. And I just want to acknowledge there's a lot of people that work on our smoking cessation advisory. Jeanette, who is our current coordinator for the program and works to make sure that everything's up and running. The leadership, Cancer Care Ontario and Princess Margaret, who were very behind making sure that everyone has access to these programs. I'm happy to take any questions, but I'll just leave it on my email. If anyone is in the sort of Ontario area and wanted to come to our community practice events, you're most welcome. And if there's any of those resources that are of interest to you, we're always happy to share them. So just let me know. So I can see Margaret's question. So the videos that we made, they're not linked to the iPad. The iPad education is sort of very focused, but what we do is we have some of them on the loops in the clinics, as well as the posters. The issue with the iPads is that because our smoking screening is integrated into other patient-reported outcomes, we don't want any individual aspect of that to take too long. So if people got really interested, which would be a great thing, and started watching a whole bunch of videos and didn't get to the other things that needed to be checked, that might be an issue for the other symptoms. So. It says multiple attendees are typing, so we'll just wait. Joanne's question, the slide deck. I think it was recorded, but Stephanie will know for sure.
Hi, Joanne. Yes, the slide deck will be distributed along with the recording.
So to Jenna's question, the funding. So our funding comes from Cancer Care Ontario. So each of the cancer programs receives funding from Cancer Care Ontario to support the screening program and the reporting of information to them. And then we've picked up some extra pots of funding. The study that we did that developed CEAF and implemented in the clinics was a grant from the OICR, and we've worked with some organizations to have some funding to build some of those educational resources, which is why we're happy to share them, because there is a cost to making them. So we're happy if anyone needs them to share them. I didn't see the whole question. There was a question about NRT and its impact on treatment. So one of the groups I know that was most concerned about that was some of my colleagues that do microvascular surgery and reconstruction. So I'm a head and neck radiation oncologist, and some of the people that do reconstruction in head and neck surgery, flaps and other things. Obviously, they're concerned about the microvasculature because you don't want to have a flap that doesn't survive. And my understanding from them is that the NRT actually doesn't put the flap at increased risk. The hypoxia from smoking is probably more risky. I don't have the reference for that just on the top of my head, but if it would be useful for you, let me know, and I can ask my surgeons what it was, because we did have quite a long discussion about that, actually. Oh, Monica's question. Yeah, so the rise of HPV-related cancers in the head and neck. So yes, there is an epidemic of HPV-related cancers. There is still the vast majority that are tobacco-associated. And I think the other story that's really coming out of that is that if you look at actually the new staging system and you look at some of the clinical trials that are being studied in the HPV-positive era, we actually know that tobacco use and tobacco history is a very, very strong prognostic issue in HPV-positive cancers. And so for the de-escalation trials, if you have more than a 10 or 20, it depends on the trial, past your history, you're actually not eligible for some of those de-escalation trials. So some of the benefits or the survival advantages of having HPV-related head and neck cancer may not apply if you have a strong smoking history. Brian O'Sullivan was one of the authors on one of those publications that actually broke down by TNM stage and tobacco history, and there are others. So it is really important in people that have, one, a curable head and neck cancer, like some of the HPV-positive cancers, that we get them to quit, because we don't want them to have a subsequent cancer that either is a lung cancer or an HPV-unrelated cancer. So to Kelly's question, I don't know anything about cervical dysplasia and smoking cessation.
Okay, so it looks like the questions have wrapped up. Thank you so much, Dr. Giuliani, for that very informative and interactive webinar. And thank you to everyone who attended. The chat was very engaging. So again, if you missed it, this webinar has been recorded, and I will be distributing this slide so you can share it with your colleagues. Remember, a link to the evaluation and post-learning assessment will be distributed this afternoon, and you will have 1 week to complete it if you would like a letter of completion. If you participated as a group, please email teach@kmh.ca with a complete list of participants by 2 p.m. Our next Teach Educational Rounds webinar will be on February 20th, and the webinar topic is Intersectionality and Tobacco Addiction Treatment, and this will be presented by our very own Megan Barker. And Teach needs your input. We are asking for you to complete a short needs assessment survey to help us inform our future programming, and you have a chance to win a free book. I will distribute the link to the registration and the needs assessment along with the slides. And again, if you have missed today's presentation, interested in viewing it again, or you would like to view previous webinars, a list of our archived webinars are found on our website, so you can view them there.